All right. Okay. Let's continue with part 3 of reviewing IEA pathology questions. Okay, so this question, we got a 30-year-old female, mass in her neck, that increases in sight. That she feels that she's more thirsty than usual, increased urinary frequency, um, heart palpitations. Okay, family history of thyroid cancer. Okay, family history of thyroid cancer. That by itself makes me think of something like MEN, multiple endocrine neoplasia syndromes. Pulse is high, blood pressure is high. Okay, so thyroid cancer, blood pressure is high. High blood pressure, it makes me think of pheochromocytoma. Temperature is okay, respiration is a little high. Respiration is okay too. Calcium is high, right? So calcium is high, and parathyroid hormone is also high. So what we have in this patient is pheochromocytoma right now, uh, and we have a parathyroid kind of adenoma. Okay, so we have one P here and one P here, right? And we have medullary. We have a thyroid tumor. We know with MENs, it's the medullary thyroid tumor that's associated. So we have medullary thyroid. So we have two P's and one M, right? This makes it meant to be. I'm gonna explain in a second what I'm doing here with the P's and M's. So we have meant to be, and so sorry, meant to A, meant to A, meant to B would be one P and two M's. Again, I'm gonna explain what I mean. I think it's the next slide actually. So it's meant to M. Now the thing you gotta know is that for meant to, let's wrote A again, meant to A. For men 2A and men 2B, the gene we are thinking of is the RES gene. The RES gene. So this is our answer. For men 1, the gene is called men 1. So our answer is C. Uh, so explanation for men 1 and 2 and 2A and 2B, you got men 1, men 2A, men 2B, right? So for 2A, which is the one we just went through, for 1, we have P, P, P. We have three P's. For 2A, we have P, P, M, and so one of the P's is pheochromocytoma, the other P is parathyroid uh, adenoma, and the third one is medullary carcinoma. For 2B, it's again pheochromocytoma, so one P, and then we got medullary, and we got mucosal neuromas. So one P, two M's for 2B, and for 2A is two P's, one M. For 1A, we have parathyroid adenoma, right? We have pancreatic tumor, and we have pituitary adenoma, right? So P, P, P. So the way you think of it is first one has three P's, second one has two P's, third one has one P, and then the ones that are not P's are M's, right? So like have this down. There's gonna be many questions on this throughout the boards. All right, next question is one that I got wrong initially. 55-year-old man, uh, severe headache, sweating sensation that his heart is racing. Okay. Uh, so has been happening for the past 3 months, especially when he feels stressed. Has high blood pressure. Blood pressure is too high, 160 over 96. And the metanephrine and VMA, which is vanillyl mandelic acid, is high, right? Ultrasound of abdomen shows mass superior to the right kidney. So pheochromocytoma, again, remember that pheochromocytomas make epinephrine and norepinephrine, and when epinephrine and norepinephrine break down, they first get broken down to metanephrine, and then they get broken down to VMA. Uh, and that's what we use to test for this. And so it's asking for the mutation that's associated with this condition. So as we said, pheochromocytoma is not for men one, right? Because men one, what is associated with it is pause the video and like quiz yourself if you can. But adenoma, like parathyroid adenomas, so parathyroid and pancreatic, and what else? Parathyroid, pancreatic, and pituitary, right? RAS is really not the context for it here in the context of MENs, or in fact anything that I can think of. CMYC is for Burkitt's lymphoma. BRAF is for BRAF. You have a couple places. Two that I can think of off the top of my head is actually GI cancers. Some colon cancers, and melanoma, maybe something like that. Uh, but this case, because we have pheochromocytoma, this is like a MEN 2. Now, either it's a 2A, which is, um, more um, characteristic is the parathyroid adenoma doesn't, and for B is mu- the mucinous neuroma, something like that, right? So, but they both have pheochromocytoma, so D is the answer. So the reason I got it wrong is that I just simply didn't know all this when I was writing the question. So this one, we have a 34-year-old has lost some weight. There's palpitations, blood pressure is a little high. Uh, T3 T3 T4 is elevated, but TSH is low. There's also antibodies against the thyroid stimulating hormone receptor. So this is great, right? Which of the following has similar mechanisms to this diagnosis? So remember that every time there is like an antibody against something that's on a cell, so in this case the receptor is like here, and there is antibody against it. This is a type 2, right? And so you're looking for something that's type 2. Allergic is type 1. Systemic lupus. Lupus is a lot of type 3. Polyarthritis nodosa. Uh, this is a lot of type 3. Remember, polyarthritis nodosa is associated with hepatitis B, and that's because you get a lot of antigen, like antibody complexes that end up kind of like happening near the vessel walls, and that causes damage to the vessel walls. Again, hypersensitivity pneumonia, hypersensitivity, and allergic reactions are both like type 1 stuff. So good pass resist. If you remember, good pass resist antibody against the basement membrane. So that's like antibody directly binding something, right? That's like a type 2 again. So I don't know what this has. Oh, I got this question also wrong. Let's see where I made a mistake. 32-year-old has 32-year-old man, uh, left flank pain and hematuria, uh, substernal chest pain exacerbated by eating that is not relieved by antacid. So I can't think of. So it's got some kidney pain and some like heartburn. I can't think of anything right now. An X-ray of the abdomen shows several radiopaque stones within the late left kidney. So, so we know that the pain is from the left kidney, right? And it's from like stones, some sort of stones. Which of the following tests should be used in the future to screen for the most likely condition? I don't know what the most likely condition is, but that's a good exercise because a lot of times you don't know what's exactly going on, but you're understanding some parts of the question. And you have to like work on your guesses. So let's make an educated guess here. Um, Hmm. I'm gonna pause this. Think about it for a second. Okay, I can't pause it. I'm gonna look at the answer. B. MRI of the head. I don't know what's going on here. Maybe they're going for a. Yeah, I don't know what's going on. Yeah. 22-year-old, hypothyroid, super low blood pressure. She's lethargic, hyperpigmentation of skin, right? Okay. So, low blood pressure already made me think of, in the context of endocrine that you're doing, made me think of, for some reason, cortisol is low, right? This is important. Know this, right? Cortisol makes the vessel cells express beta and alpha receptors. When there's no cortisol, there's no alpha receptors, so the vessels aren't responding to the natural levels of dopamine and not dopamine, epinephrine or epinephrine. So you lose blood pressure. You also got hypothyroidism, right? And you got hyperpigmentation of skin. Hyperpigmentation indicates ACTH is high, right? Um, and you got 60, glucose is really low, right? This also makes me think of what? Makes me think of low cortisol. I can still tie in the hypothyroidism with all this. And then it says, so IV saline and prednisone is administered. What's the most likely cause of the most likely cause of this patient, right? So what I can think of is that it's a young guy, right? You know, uh, it's lost cortisol, but it still has ACTH. That means the problem is within the adrenals, right? So it could be an autoimmune disease, it could be bilateral adrenal hemorrhage, it couldn't be ACTH deficiency, it couldn't be thyroid hormone replacement. Ectopic ACTH production also doesn't make sense because you would have high cortisol here. So autoimmune disease and bilateral renal hemorrhage. I'm gonna go with bilateral adrenal hemorrhage, and let's see if I'm right, and then I'll explain why I'm wrong. Okay, so I guess what they're wanting you to think is that this person has also lost cortisol, thyroid function. So there's probably something autoimmune going on that. Uh, oh, and then there's prednisone started. That's another clue. Actually, that doesn't tell us much. But because there's also lack of thyroid, maybe there's an autoimmune process that's affecting the thyroid hormone as well. So, but what I was thinking is that when you have this is a kind of a young person, right? So, with young people, the Neisseria meningitidis infection can lead to the Waterhouse Friderichsen syndrome thing, and that is like has like a similar presentation to this, and kind of young college age people are more susceptible to that. So I was going that way. 43. I like these questions because they challenge me, and it's sometimes good to get some wrong. It just makes you feel like your time is worth getting spent upon them, because otherwise you're just like regurgitating stuff you already know. 45-year-old, just has gained some weight. She was diagnosed with lupus 20 years ago. She's had undergone replacement surgery 2 years ago due to necrosis of the femoral head. Blood pressure is 140, a little high. Truncal obesity, abdominal striae, proximal muscle weakness, mild hypoglycemia, what does her adrenal glands look like? So she's already on a lot of like the symptomology described here. Abdominal strain, proximal muscle weakness, hyperglycemia. Um, it's also, I don't know if you caught it or not, but it's also describing like some problem with the hip. To me, that's like a kind of like not exactly osteoporosis, but it's like that corticosteroids slow down bone mineralization. So maybe that also is what led to the hip replacement surgery. I'm kind of sure what they're going for here. So we have this patient was also diagnosed with lupus. I don't think anywhere in this question has told us the patient is taking corticosteroids, but everything kind of like makes sense. So we're assuming this patient is on exogenous corticosteroids, right? So if that patient is on exogenous corticosteroids, ACTH goes down, right? And that in turn, our endogenous corticosteroids go down, but that means our adrenal glands, which look like this, will also go down. So they get smaller. So and it's bilateral. So bilateral cortical atrophy is what I'm going with. B. Okay, let's see if I remember this. 47-year-old, high BMI, a high glucose. Uh, oh yeah. So 47-year-old has diabetes, basically, high glucose, super high BMI. Is type 2 diabetes. What is the predictor? What causes um, this genetic condition is familiar history of similar symptoms. So remember that type 2 diabetes is also correlates with like genetic stuff, but it's not a particular gene. It's more like a familial like pattern of predisposition. It's like polygenic. So the answer is D. HLA-27. This is like predisposing factor for a bunch of stuff, for seronegative arthritises, also for some like Reiter syndrome, some like ankylosing spondylitis. Pretty sure it could be like Crohn's disease, something like that too, but don't quote me on that. These two, 3 and 4, I'm not exactly sure. I think they're for type 1 diabetes. 47-year-old, 10 pounds of weight loss. Uh, there is a mass in the thyroid, hypoechoic thyroid nodule with microcalcifications. That's Pisoma. That's soma bodies. Pronounce the P. Um, they gotta remove the thyroid gland. So what type of cancer is this? It's a thyroid cancer, but what subtype? It's got soma bodies. Remember, soma bodies are formed as a result of calcifications around like finger-like structures, right? So it's a papillary cancer of the thyroid. It's the most common one, right? Which one of them is a predisposing factor for this? A mutation in the ret oncogene, that's for medullary, right? Thyroid hormone replacement, I don't think that's a risk factor for anything. RAS mutations, RAS, I don't know if it's a thing here, but I do know it can happen in colorectal cancer a lot. It's KRAS, I don't know if it's the same thing, but I'm gonna go with either A or C. I think I think it's C. Yes. Ionizing radiation, especially in childhood, predisposes people at uh, developing thyroid cancer in the future, and especially like usually like people who've had like some sort of cancer, some sort of they needed to be radiated up here as a kid, they'll develop this type of cancer in the future. So 13-year-old girl uh, is found unconscious. Uh, Okay, so she's got labored breathing and fruity odor, so kind of like cluing into a type 1 diabetes. And what's seen in histology, is it soma bodies? Is it samoma bodies? No, that's like, it sounds like cancer to me. an area of prefer clearing around finely dispersed. I don't even know what's the description of this. Uh, but that means if you don't know what an answer choice is saying, to my experience, eliminating that answer choice is the best. Unless you're extremely sure none of the other ones are the answer, and even then, most of the time, something you don't know what it is never the answer. Diffuse lymphocytic infiltration with formation of lymphoid follicles. Okay, so type 1, diabetes type 1, we know it's a type 4 hypersensitivity. So C is not that crazy. Chronic inflammatory infiltrates, amyloid deposition. Uh, for amyloid is for type 2, and between chronic inflammatory infiltrates and diffuse lymphocytic infiltrates with formation of lymphoid follicles, I'm going with B. um, because lymphoid follicles is kind of like a this is a description of kind of uh, Hashimoto's arthritis, thyroiditis, and we don't have follicles because it's mostly T cell mediated response. Okay, so this is an MEN question, multiple endocrine neoplasias. 25-year-old, lump in the neck, uh, history of seasonal allergies, 2 centimeter nodule in the thyroid. So we got thyroid tumor. Interesting. Multiple papules on the lip and uh, a large arm span with long fingers. So one thing I forgot to mention. So multiple papules on the lips is a description of mucosal neuromas, right? If you remember, that is a meant to be characteristic. That's the last M. This M is medullary carcinoma. This is pheochromocytoma, right? And these guys have morphanoid appearance, so it also describes a large arm span with long fingers. So you remember what else has morphanoid appearance? Of course, Marfan syndrome. Uh, what else? So homocystinuria is one of the other ones, right? Uh, can't think of anything else, just these two. Okay. So the question says, what other finding most likely to be seen in this patient? Uh, Hypercalcemia. This is likely with one of the pituitary adenomas, which is seen in men 1 and men 1A, not men 2B like we have in this question. We have distal duodenal ulcers. This is, when you have a tumor that kind of produces gastrin, because gastrin activates the parietal cells that produce a lot of acid. So that's not the answer. Bitemporal heminopsia, that's like when you have an adenoma of the pituitary. Episodic headaches. Episodic headaches. Because of pheochromocytoma, we get episodic headaches because of the episodic hypertension. So this is the chart I was talking about. I think it's from first aid. You got 3Ps: pituitary adenomas, parathyroid adenomas, and pancreatic tumors. For men 1, for men 2B, you get parathyroid adenomas, pheochromocytomas plus medullary carcinoma of the thyroid. For 2B, you have pheochromocytomas. You have mucosal neuroma, as it says here, and also, again, thyroid medullary carcinoma. And 2B here, you have marfanoid appearance, right? 54-year-old woman, nausea, vomiting, increased frequency of urination, increased thirst, hypertension, hypercholesteremia, and bipolar disorder. Okay. All right. So interesting question here. Increased thirst and frequency of urination was immediately like making me think of, okay, maybe diabetes insipidus, maybe like diabetes mellitus, diabetes insipidus. And then I saw bipolar disorder. That just immediately, I'd be surprised if this is not a lithium question. So this patient is probably taking lithium for bipolar disorder that caused a nephrogenic diabetes insipidus, and that's why we get the increased urinary frequency and increased thirst. But let's read on. I may be wrong. The physician believes that a woman's symptoms are adverse to the medication she's taking. Yeah, okay. Which are the following laboratory studies would you? Oh, so what would you see? Expect to see on laboratory readings, right? Okay. OGTT of I don't even know what OGTT is. If I don't know an answer choice, I move on to the next one. I usually don't never pick something I don't know. Urine osmolarity of 290, and normally says less than 295. Post vasopressin administration. So vasopressin, when you administer it, is basically an antidiuretic hormone. So when you give a vasopressin, it should cause antidiuresis, meaning it should suck all the water out of it, meaning you should have a super hyperosmolar urine, right? So when your urine is still not hyperosmolar after vasopressin, that means your kidney is not responding to the vasopressin, and that means you have kidney or like nephrogenic diabetes insipidus. So I think B is the answer. Uh, there's nothing to do with ACTH. There's nothing to do with TSH either. So I'm going with B. Okay, 65-year-old woman. Uh, there's she's scared of developing breast cancer. Okay, so this is one of the risk factor questions. She's started having her periods at age 13, had 3 kids, menopause at 58. So it's a um, no family history. Which one of them is the biggest risk factor for my sorry, what? For risk of developing breast cancer? First of all, there's nothing about radiation exposure here. There's nothing about family history. Nothing about this. So basically, we got to choose about early menarche and late menopause. So honestly, if I before seeing this question, I didn't know what to go with, and that's the star. But the answer is B, and I think I have a good explanation for that. So what basically the reason these two things matter is because if you have early menarche, let's say if you've had your first period when you were like, I don't know, 10 instead of like what the average is, which is 14, right? Your like breast and your uterus and everything has have seen high levels of estrogen for 4 extra years, right? And same story with late menopause. If like let's say average is 50 or 58, you have had like 8 years of extra hormone, you know. So in this case, this 58 is high and this 13 isn't that low. So that should clue you more into the late menopause. And the other thing that I think is important, like I don't know if this is true or not, it's just the way I think about it, is that because like menopause happens later in life, you're like kind of pushing like old tissue, and that's always like more of a risk factor than comparing than pushing young tissue, risk factor for carcinogenesis, that is. So I would go with late menopause over early menarche if I was given the choice between the two. So you can see all the risk factors here. 42-year-old, uh, some weight gain, some constipation, brittle hair, okay, edematous space, hypothyroidism of some sort. Uh, the sister has had some similar uh, symptoms.